And thanks for this opportunity. It's a big honor being here, because all what we do is for the patients, and it is a very good thing to be able to explain what we do, how we do it, and why. Unfortunately, when one mentions the emergency department, everyone says waiting time. And it is something that it's there, but you will understand, I hope you will understand why it is there. We don't like it. I wish that everyone who comes there, we just snap our fingers and they are ready. But there is a process, and there are resource limitations. So let's start. What is the emergency department? So the emergency department, the main name is to offer emergency care and care for the urgent medical cases. In Malta, it is one of the most important admission pathways. Okay, so most of the patients that end up in Mater Dei as inpatients, most of them pass to the emergency department. Shouldn't it be that way? Questionable, but that is not in my remit. Also, the emergency department is an important fulcrum in case of a disaster medicine. So if there is a major disaster, and in Malta, due to the capacity of the hospital, a disaster is an incident where 6 people, only 6, are severely injured. So it is not something common, but it's not something very uncommon. A medical emergency, and I'm saying this to put everything into perspective. A medical emergency is an acute injury or acute illness where the patient is in a situation where they can lose their life, lose a limb, arm or leg, or else remain with a long-term disability. So that is an acute medical emergency. An urgent one is that right now you're not in the emergency state, but if you are left untreated, you will soon become an emergency case. So these are the two main category of cases that we should be seeing. We also see a large number of non-urgent cases, i.e. cases that could be seen somewhere else. I'm not saying just in the primary health, but also, for example, in outpatients. Just for you to know, around 80% of the patients who attend the emergency department are not referred. So they come there as their first port of call, 80% of the cases. I want to go back a few slides. And I wrote a unique service, and I wrote it for 2 main reasons. The first reason is that emergency medicine is a specialty. It's a specialty on its own. So after the 2 years that each doctor has to work with the government before they give him the license to practice, to become an emergency specialist, you need another 7 years minimum of training. We're saying 7 years if everything goes according to plan. In those 7 years, the trainee has to go to 2 foreign exams, one between the 2nd and the 3rd year, and then one at the end. And the emergency specialists, apart from the knowledge, they have, like GPs, have to have good communication skills, good logistics and resource allocation, so on and so forth. The other thing why it is unique is because on this island we only have one emergency department. Do you know how many emergency departments are there in London? In London only? 20. On this island we have one. Obviously their population is bigger. But when we're full, we can't close the doors and send people to another emergency department. We never close our doors. So full, how much full we are. Cubicles, people still come in and we will still see them, sometimes with a waiting time. The emergency department does not depend only on emergency physicians, far from it. There are at least 12 categories of colleagues. So nurses, physiotherapists, EARs. EARs are the ambulance drivers. They are not ambulance drivers. They are not just anyone who can drive a van. They have specific training. So clerks, receptionists, radiographers, ECG technicians, and so on and so forth. In total, to offer the service 24 hours a day, 7 days a week for the whole of the year, there are around 500 people working there. Now, at the sections, the pre-hospital, so the pre-hospital is the ambulance service. We manage around 120 to 150 ambulances per day. So around 120 to 150 patients are brought into the emergency department by ambulance every day. We don't send all ambulances the same for each patient. We have to prioritize. It's not about the van, it's about the human resources. The van can be an van, but without the skilled people inside it, it's just a van. Okay? So we prioritize the ambulance calls according to what the caller is saying. That's why if you unfortunately had to phone 112, there is someone who is asking a lot of questions. It's not because we are nosy people. It's because we want to deliver the best service to the patient. And nursing, like in all other areas, is not as available as it was a number of years ago. Okay, so it's not uncommon that in 2 hours we would have 20 to 25 ambulance calls. I don't have 25 nurses to send out. It's simple, not there. I don't have 20 nurses for the whole department, let alone to send on the ambulances. So one has to appreciate the limitations. Okay. To try and maximize the use of limited human resources, last year, before my time, the rapid response vehicles were introduced. So these small vehicles with equipment sometimes precede the ambulance, because really and truly it's not the ambulance, it's the service that needs to reach the patient. So that is from the pre-hospital side. The in-hospital, so average we receive between 250 to 210 patients, adult patients every day. Okay, and we see them in around 30 cubicles. Okay, not more, and we have to prioritize. And there is a tool called ESI where the nurse in the first door will allocate a priority. Okay, so ESI 1s are those that are dying now, 2s are urgent, 3s are urgent but not time critical, 4 and 5, those could have been seen somewhere else. Out of the 210, usually only around 40 to 50 are of the lowest priority. The rest would be cases that need assessment. And I will explain how it's done. So those are the areas in the department. MCC here, although the primary health also has that annotation, ours is minor care clinic. Okay, so area 1 and 2 are where we see the ESI2s. Resuscitation rooms are those rooms there that where we see the most critical. Just for you to understand, if a motor vehicle accident, a car accident with severe injuries is coming in, that case would use a minimum of 3 to 4 doctors and 1 to 2 nurses for a minimum of 1.5 hours. So the human resources are what they are. We have increased. When I started so many years ago, the night shift, we would have been 4 doctors only. And I think you remember that. Today, they would be around 12 to 15 doctors at night. But to manage everything, 12 or 15, let's say a car accident with 3 people. 9 are out of action for so many hours. Area 3 deals with those cases that need investigations, and I will explain why it takes some time. And all it has right now is a number of cubicles. Out of those 30, it's 6. MCC is minor care. So the visit is not a single visit. So most of the time, when you go to a GP or someone in outpatients, you go in, you're seen, you're out, and that's it. Here we're talking about a different system, and it is a number of interactions, and I will explain why. So, as you know, when you arrive at the emergency, you go at the reception. Sometimes even there you have to wait, because it's not uncommon that within, let's say, half an hour, there will be 20 to 25 registrations. So until it's your turn, you have to wait for those. We have 2 or 3 receptionists all the time, but even that will take some time. Then you're triaged, and triage usually take 5 minutes per case, but if you're at the number 20, another 19 were before you. So up to triage usually is according to your registration, plus or minus, because if there are certain signs, they will be called in before. Then you'll be given a triage category, and then is the waiting time for the cubicle. Now, cubicles, they are not infinite, and once you come in, you'll be seen by the doctor. They will take blood investigations, they will have x-rays, they will wait for the investigations. Maybe some would show something that needs further investigations. So there will be a number of assessment, investigation, observation, assessment, so that will take some time. Then a decision is made if you're staying or be discharged, and then one has to start waiting for the bed. Waiting for the bed does not depend on the emergency department. So we will request a bed for Patrick Farrugia, and when the bed management locates or vacates a bed, he will go up. But that sometimes takes 2 or 3 hours. So if I have 30 cubicles and half of them are full with patients awaiting to go up, I have only 15 cubicles. But worrying signs, the rest are not visible. These are the signs that if they are present, we would expect people to come to emergency immediately, not go to the health center. Why? Because if there is loss of consciousness, I know that Glenn and his team do not have all the required resources to investigate safely. It's not just the investigation, you have to do it safely in an environment that if something goes south, you can do something. If there is a sudden confusional state. So these things are, let me try and, no, I can't. These things are things that should come immediately to the emergency department. Okay, so severe bleeding that cannot be stopped. Now, severe bleeding, I'm not saying some epistaxis and within 30 seconds, but there are injuries or people who are on warfarin. One cannot not mention people who are on chemotherapy. If there is fever, that is an issue, so those need to be investigated and investigated well. So, in fact, it is written down there. A breathing difficulty. If it is minor asthma, and I know that I am an asthmatic, and usually if I go to health center, they give me the treatment and I'm fine, that's one thing. If I am an asthmatic and I have been admitted to ITU a number of times, that's a different thing. So this is the balance. There is no list that I can ever give if you have only these calm, because each case is a different case. Something that one might think it's very grievous might not be that way. But certain things are obvious. So severe bleeding, loss of severe headache, that it is the worst headache ever. Those things need to come to our department. And as I said, our cohort is multi-stage, is multi-stage, so I examine, I investigate, I observe, I examine again, until I am sure that I will send you home safely, because now you're at the secondary level or tertiary level, and multi-class. So I might be seeing someone who is literally dying, while I am seeing someone who came in with toe pain. So my mind has to switch from one thing, and people get fatigued. I'm like that. That is the best picture that explains an emergency department. It's a conveyor belt, and it's very simple. So if the workers are, the doctors and nurses there, the flow of the patients depend on the speed of the conveyor belt. That is mainly how quick they will give me back my blood results, how quick they can do that CT scan, how quick they can do the ECG. And it depends on how quickly they will vacate my cubicles to go into the ward and how many patients are coming in. And because I can be safely as fast as I want. If the number of patients coming in, it's too much. And I can't say, your priority is low, so I leave you there. But that is why there is an amount of waiting time. Some misconceptions, I've heard them over 22 years, and I would like to share them with you. Call an ambulance so they see you earlier. That's false. Each case is triaged. I've been involved in cases where an ambulance is called because I'm severely short of breath, I'm dying. You go and you find the patient on the pavement with the case waiting for the ambulance. If I'm severely short of breath, I wouldn't be there. So that is a misconception that a number of people would use the ambulance service to try and get a quicker service. It does not work, unfortunately, that way. Ambulance to transport back home. Every day I have 11 ambulances to work with. If I have ambulances waiting to go out to get patients in, I will not use those to transport someone who is good to go home, because by definition, that is not a priority. I wish I had 100 ambulances because I would use all of them, but it doesn't work that way. Għamilli pjaċir żommni jumejn. Do me a favor, keep me in hospital for 2 days. Really and truly for me, it doesn't really matter. In matter of fact, it's easier. It is safer for me to keep you 2 days in hospital. It's less responsibility than sending you home. But if you get a hospital-acquired infection and you die of it, it's my responsibility. If the next patient that really needs the bed doesn't have the bed, it's my responsibility. So it's not pjaċir. Qed nagħmellek pjaċir qed nibatek id-dar. Complaints, we receive a lot of complaints. For a slight headache, I spent 4 hours waiting. Most probably, you could have been seen by a Department of Health and you would have had a better service, because waiting is a poor service. I wish no one waits, but... And kolla bil-qeda ma jagħmlu xejn. So, as Dr. Glenn Garcia said, today everything is electronic, okay? So, ordering of bloods, of investigations, seeing results, writing notes, old notes, seeing ECGs, booking out patients, everything is electronic. So you have to sit down and write. Our patient records, there is a template, and it will involve all the body systems, because we are now in the secondary level of care. So not because we want, it's because that is how safety netting goes. So I have to look at your heart, at your lungs, at your tummy, at your legs. So it is a process, and I have to write it down. Because at the end of the day, if something happens and I don't write it down, I go to court. It's very simple. So one has to understand that writing down is to protect the patient, so there is continuity of care. And also, if I did something, I need to document it. Or else, ġejt għall-X-ray. No, you came with a symptom. Radiation is a dose of radiation. Okay, so X-rays are a dose of radiation. A CT scan is a number of X-rays. So just for you to know, an abdominal X-ray is around 200 to 300 chest X-rays. That much. If you need it, you need it, but I won't just do something, an investigation, just so you feel good that I ticked a box. Unfortunately, we do have a lot of people who come for an investigation because they heard that their friend needed this, so I want it. It is, as I said, it's easier for us. You want a CT scan? But that's not a good service. A good service is that I give you the radiation that will do a difference in my decision about your health. All these are a small number of comments or misconceptions that I've heard in my lifetime in the emergency department. I skipped all the rude words and all the vulgar accusations, because obviously I'm saying to give a good image. So that's from my end. Any questions? I think.
So thank you both.